welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website, nahatica.org, within our webinar library. After completing this webinar, please complete the quiz if you're interested in receiving a certificate. You can find the quiz on our website next to the Watch Now button you selected to view this webinar on our website. If you're a member of NAHATICA or NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You'll receive a certificate worth 1 CE once you've completed and passed the quiz and paid for the webinar, if applicable, within 10 business days. Throughout the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for alcohol and other drug use professionals, as well as the MBCC. If you have any trouble viewing this webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to traininginstitute@nahatica.org. And with that, I'm going to turn you over to Angela Thomas-Jones to talk about addressing compassion fatigue in clinical supervision.
Hello, everyone. I'm glad that you're here with me today to look at this very important subject matter of taking care of ourselves. This slide shows the variety of credentials that I hold. I've worked in New Hampshire since 1988 with license as an alcohol and drug abuse counselor, and now as master licensed alcohol drug abuse counselor. I also hold license with the Mental Health Board as a clinical mental health counselor, and am approved in the state of New Hampshire as a clinical supervisor for mental health candidates, as well as those applying for addictions recovery licensure. In addition, you can see the picture of myself and my border collie Panda. About 10 years ago, I was able to complete the training with International Therapy Dog Association, and she accompanies me with most of my work. I've worked also with Dr. Bezel Vanderkock and completed their advanced certification in trauma-sensitive studies, including trauma-sensitive yoga practices. And I also hold International Association of Trauma Professionals certification in compassion fatigue. The goal for this material is best described by flight attendants when reviewing emergency procedures before takeoff. Put your own mask on first, then help others. The fact that you fit this hour into your busy schedule means you're already thinking about, or maybe even taking action on this topic. As providers, we must take care of ourselves in order to take others. This is much easier said than done, right? The evidence for the causal relationship between provider resilience and wellness, the safety and quality of care provided to consumers, has gained national attention. Earlier this year, the World Health Organization announced its revised Handbook of International Classification of Diseases, the ICD-11, due to go in effect 2020. It calls burnout an occupational phenomenon and includes it in a chapter on factors influencing health status. And they define burnout as, quote, chronic workplace stress that has not been successfully managed. End quote. In New Hampshire, for addiction professionals, the licensing board regulations identify the National Association for Alcohol and Drug Abuse Counselors Code of Ethics as the standards for all of their credentialed professionals. Here I've highlighted 3 of those 9 principles that reference to self-care or self-monitoring, as well as self-monitoring for impairment. Today, we're going to review proposed practices currently being tested here in New Hampshire for certified recovery support workers as well as clinical mental health counselor candidates. This material is quite dense, so if you can go ahead and read the slides on your own, that'll economize our time while I talk through the material associated with the slide. So the purpose of this project, one, is to utilize the Informed Consent Supervision Agreement as a means to maintain patient care and safety through relevant, effective, and sensitive management of chronic workplace stressors, including compassion fatigue, burnout, and therefore, two, by doing this, contribute solutions for building a resilient and sustainable workforce where workers can thrive, doing what we're called to do. During the past 18 months, this material has been presented in various settings across the country and has gained momentum as a collaborative project. It's important for me to say that this is not a one-solution-fits-all approach, so your feedback, continued conversation, and collaboration is welcome. A copy of the presentation is available by sending me a request at the email in the lower right-hand corner. And I'm glad you're listening and hope this information will be a productive use of your time today. Highlighted here are two references from the 9 principles in the NADAC Code of Ethics, giving clinical supervisors and workplace managers the directive to take steps to assure supervisees and workers have appropriate resources and competencies, and to ensure current knowledge and information is being utilized. Today we'll be reviewing evidence for the urgent need here in New Hampshire to update these resources and competencies to more adequately address and manage risk encountered in today's workforce landscape. In the fall of 2018, my sister Cynthia Thomas and I were pictured here on the slide, and several colleagues who met regularly for peer collaboration initiated a grassroots effort based on the results of a provider needs assessment Cindy and I designed based on the Professional Quality of Life survey. The results helped this initial effort gain momentum. By the end of 2018, this effort became the North Country Task Force to Improve Opioid Treatment Outcomes by addressing provider well-being, and was awarded a technical assistance grant through the Opioid Response Network. I'll talk more about this later. Here this slide shows an article that was published by the Opioid Response Network in their community stories, and the author does a great job describing the intimate nature of this project. You can read the full article by going to the Opioid Response Network website and click on Community Stories. You can also visit the Granite State News Collaborative. It's up in the right-hand corner of the slide, the reference, on YouTube, and select Solutions from the Front Lines to hear my full testimony among several others on this topic. Throughout the presentation, I'll be sharing from my own lived experience to help illustrate some of the concepts and issues. You'll have the opportunity to encounter exercises in the Informed Consent Supervision Agreement. These are somatic exercises meant to engage the mind and body for affect and mood regulation specific to the risk factors we experience in today's work landscape. Somatic means of the body and originates from the Greek word soma, meaning body. Somatic skill development is essential for calming the stress response of the mind and the body. Being resilient means having the ability to bounce back, and this means knowing how to calm the stress response. This skill can be learned. Sustainable workforce development depends on resilient, healthy workers. The next several slides review the research and terminology that define this material. During 2017, I experienced a turning point in my own personal and professional life that led me to establish a professional resilience plan with the following goals. Invest time and energy with colleagues mutually invested in raising awareness and identify effective solutions for the ethical imperative defined as self-care, and decrease stigma in our work culture for talking about the hidden toll of this work we're called to do. After researching how to move forward, I found the mission of the New Hampshire Alcohol and Drug Abuse Counselors Association to be the most in alignment with my professional resilience plan. So I joined the Nahatica Board of Directors as the North Country Regional Representative and now also as the Ethics Committee Co-Chairperson. The provider needs assessment I've mentioned was created and facilitated as a means to better understand the needs of my North Country colleagues. And this slide is an image of that summary report. The Professional Quality of Life Survey is a validated tool available free online and was used to develop this provider needs assessment we've mentioned. This particular slide is from the materials available on the ProQual website. The ProQual survey is a 30-item self-report measure of the positive and negative aspects of caring. Compassion fatigue, as you can see here in the diagram on the right, has two subscales, burnout and secondary trauma. As mentioned previously, WHO defines burnout as a syndrome associated with unsuccessfully managed workplace stressors. And they go on to say, characterized by, quote, feelings of energy depletion, of exhaustion, increased mental distance from one's job, or feelings of negativism, cynicism related to one's job, and reduced professional efficacy, end quote. Here in New Hampshire, our resources do not meet the need for substance use disorder treatment. Needs exceeding resources is a contributing factor to burnout. Secondary trauma, also called vicarious trauma, is the side effect of bearing witness to trauma or disaster. Bearing witness occurs as a bystander at the scene, including violence viewed in the media. In the case of behavioral health, as therapists, counselors, peer workers, and medical providers, bearing witness comes from listening to the histories our clients and patients report to us. Emergency room staff bear witness from both hearing about and treating the physical wounds. Public safety officers, first responders, firefighters, enlisted military, and so on are directly involved at the scene. So being impacted by the work we do is inevitable. Although we cannot control the occurrence of crisis and disaster, we do, however, have choices. Choices how to respond. Therein lies the key to effective management of workplace stressors. The next several slides outline details of learning objective number 3, be able to list the stages of the stress, distress, impairment continuum. Sometimes a picture tells a story better than words, and I found that to be true with communicating and understanding the 6-stage continuum here. So due to today's time frame, I'll briefly review this continuum rather than unpack the symptomology for each stage. The next several slides are from a publication called Advancing Colleague Assistance in Professional Psychology, and it was published in 2006 by the American Psychological Association. Current updates can be found on the APA website. So think of the first 3 stages on the left like a traffic signal: green, yellow, orange, fading into red. A green traffic light signals all's clear, safe to proceed. This is the stage when stress is helpful. Not all stress is bad. We need enough, a healthy balance, to keep ourselves alert, focused, and motivated. Distress is the warning signal, just like the yellow light is the signal for caution. you can see the third stage is out of alignment from the others and has a transition of colors from yellow, orange, and red. This is the impairment stage. You can also see two large gray tinted arrows separate the 6 stages into 2 equal parts. The 3 stages on the left are within the scope of practice of clinical supervision and peer collaboration. The 3 stages on the right are within the practice of licensing boards, which is regulating practice to prevent harm to the consumer. It is in the nature of this professional work that individuals may develop personal difficulties that impede or impair their personal or professional functioning. The APA materials contribute to the evidence of the causal relationship between provider wellness, patient care, and safety. Their message is hopeful and compassionate. It encourages a process of accountability and transparency through trusted rapport with our colleagues and leaders, rather than a punitive approach. Impairment, while heightening the risk of ethical violations, does not infer such violations. It's not the stress or even distress that leads to impairment, but the inappropriate or ineffective means of managing stress that render the provider at risk of doing harm. So, what is impaired practice? APA defines impairment as interference of professional functioning in one or more of the following areas. I'll let you read to yourself these 3 areas. This criteria offers a framework for corrective action plan development facilitated within the supervision relationship as part of human resource and personnel department function, and of course, the licensing board process of regulation. A significant insight gained from the mentioned provider needs assessment is that less than 30% of the respondents reported receiving clinical supervision and indicated they are not talking about compassion fatigue related symptoms because of either fear of receiving a poor work performance evaluation or fear of the loss of job security. Reducing this fear and engaging meaningful, effective supervision is the primary goal for this project. So according to the APA research on colleague assistance, one of the 3 criteria defining impaired practice is so the key in those 3 criteria starts with inability or unwillingness. So the answer is D, inability or unwillingness to acquire and integrate professional standards into one's repertoire of professional behavior. I picked this particular question because I think that it helps highlight the point that effective peer collaboration, supervision, mentoring, coaching, whatever the defining word is in the relationship, is looking at what might be called mistakes as learning opportunities. These are learning opportunities that can strengthen our development moving forward. So according to Jeffrey Goldsmith, who wrote on a study related to interprofessional collaboration and how it contributes to self-care, it's an update on the APA website. And the bottom line of that document is saying that an effective collaboration shifts the focus from who is right to what is right. In 2016, the U.S. Surgeon General's report called for action by identifying substance use disorders as a public health crisis. I'm going to go back to who is right becomes right. Since the public health crisis has been announced, we've all experienced the strain, and Goldsmith makes an excellent point around how working in multidisciplinary teams is the most effective approach for establishing trusted conditions for self-closure, as well as increasing effectiveness and quality and patient safety. And he names several characteristics of what is an effective multidisciplinary team. And they are comprehensive in their scope, value the input of team members, consider each member's input as essential, and competently negotiate intervention. These principles are integrated into the Informed Consent Supervision Agreement through a solution-focused, strengths-based, and person-centered reflective model. So this completes learning objective number 3, be able to list the stages of the stress-distress impairment continuum. The next several slides will contribute to learning objective 1, understanding where to find evidence-based practice and resources to increase clinician resilience. And thanks to the Surgeon General's report that was published in 2016, this has helped to empower both federal as well as statewide initiatives to provide more integrated care to address this challenge. Here in New Hampshire, we're third only to West Virginia and Ohio with the country's mortality rates due to heroin and fentanyl overdoses. Although we're seeing evidence of positive change through more integrated care, we're still faced with the changing landscape of U.S. healthcare systems and its profound effects on clinical practice and the experiences of clinicians, students and trainees, learners, and patients and their families. Mounting system pressure contribute to an imbalance of overwhelming job demands and insufficient job resources for clinicians, causing physical and emotional stress, including burnout. This slide provides you with the references to the World Health Organization's ICD 11 reference. The evidence for how chronic stress impacts health and work productivity is indisputable. Most recently, the Adverse Childhood Experiences Study, originally published in 1998, it's gained attention because of the positive outcomes practitioners are finding by operationalizing the data from that study and implementing positive change through prevention, intervention, education, policy, and workplace culture development. WHO's definition names an opportunity for workers and administrative leaders to work together, building a resilient and sustainable workforce. The intensity of treatment needs for complex and chronic conditions continues to grow. In 2016, the National Action Alliance for Suicide Prevention released a statement in response to the CDC report identifying suicide rates by occupation. You can see some of that data listed here on this slide. The Action Alliance stated the Centers for Disease Control and Prevention data remind us that while more is being done now than ever before to prevent suicides in the United States, greater efforts must occur in a variety of settings, including work settings. The data underscore the need for increased attention to suicide prevention in work settings, on par with workplace increased attention to other public health issues like smoking cessation and physical activity. Here's additional evidence from the healthcare profession, specifically the medical field. High rates of burnout reported in U.S. clinicians and learners is a strong signal the nation's healthcare system is failing to achieve its aims for system-wide improvement. Improving the U.S. healthcare system to achieve the goals of better care, improved population health, and lower cost depends in a large part on a workforce that is functioning at its highest level. Supporting professional well-being is essential to the therapeutic alliance among clinicians, patients, and families, and the delivery of high-quality care. In 2017, the National Academy of Medicine announced a national call to action for clinician well-being. This slide shows a diagram of factors affecting clinician well-being published by the National Academy of Medicine in an extensive report titled Taking Action Against Clinician Burnout, a Systems Approach to Supporting Professional Well-being. This paper calls upon leaders in healthcare organizations and health professions, educational institutions, as well as within government and industry to prioritize major improvements in clinical work and learning environments in all settings and for all disciplines to prevent and mitigate clinician burnout and foster professional well-being for the overall health of clinicians, patients, and the nation. This call to action is based on 20 years of research stimulated by a groundbreaking report published by the Institute of Medicine back in 1999. It was entitled To Err is Human. This report revealed evidence a high number of hospital deaths were related to medical error, not because of provider negligence, but rather because of inefficient and ineffective systems that interfere with quality care practices. The task force is applying this evidence in New Hampshire, specifically in the context of the professional development of certified recovery support workers and clinical mental health counselors. This slide is from the narrative summary of the provider needs assessment that I spoke about earlier. You can email me with your request if you'd like a copy of the report. I've included this page to acknowledge the work of Dr. Tana Bridge, as mentioned at the top of the slide. You may have participated in the compassion fatigue and ACE study trainings she's provided here in New Hampshire. I first met Dr. Bridge many years ago as part of a research study she was doing on the link between practitioner resilience and lived experience. I volunteered to be interviewed as part of her study. Although I was familiar with the concept of the wounded healer, this was the first time in my career to talk about my lived experience as a person in long-term recovery from alcohol and cannabis use disorders and as a child survivor of family violence. Talking about that outside of the privacy of my 12-step self-help network, my therapist, and my doctor was a new experience. The results of that study are not yet published. However, with her permission, I included reference to her work as a validation of the concept. Resiliency skills can be developed as part of a professional development plan. It's important, I think, to acknowledge being effective as a substance use treatment provider does not require lived experience as someone with a substance use disorder. Social psychologist and researcher Brene Brown has given us several delightful examples of how the key factor in being empathetic is simply being with someone rather than what to say. She says truly helping means connection and defines this as a big part of empathy. The Professional Quality of Life Survey and its website addresses the concept of lived experience as a double-edged sword. They describe internal risk factors as the stuff we bring to work, using the phrase, quote, we bring ourselves to work, end quote. Meaning our lived experience is also potentially a risk factor in the stress-distress continuum. As you can see, and as you've heard, there's a lot of material on this topic. Moving forward, please remember to read the content on the slide while I'm also discussing the related details. That'll help us with our time frame. I've included this slide to show you how I attempted to organize the material. Most of the slides include reference to the associated learning objective in the upper left corner, as you can see here. The tan-colored sunshine icon means the item is from this workbook, Overcoming Compassion Fatigue, a practical resilience workbook, and it will include the page number. The two profiles facing each other in the center, with the word empathy connecting them, is used as a cue for interaction or reflection. Excuse me. As I said, this material has been presented across the country, and in the live version, these are turn and talk sessions where folks are interacting with each other. In our case, it would be reflection with yourself. Most of the resources in today's presentation are from this workbook identified on the slide. As a certified compassion fatigue professional, this publication is available free to those who complete my trainings on this topic. As an introduction to the workbook, it's 139 pages, so it's available electronically. I want you to hear from the author's voices. Martha Teeter says, "Our hope in writing this workbook is to offer concrete, practical tools for you to use to keep yourself energized, to do the work you're called to do. By using these strategies, you'll be able to not only survive, but thrive as a helping professional." And John Ludgate says, "I can recall how shocked I was several years ago when I heard that a very prominent cognitive behavioral therapist, who I knew slightly, and who ironically wrote articles about the need for self-care, had committed suicide. He had many colleagues and friends all over the world, so I couldn't help but wonder, did he ever talk about this issue with anyone? Did anyone even notice his distress? We'll never know, but it raises the question, how can we better look after ourselves and others in this demanding field we're working in?" Ludgate continues, "2 years ago, I learned with great concern about the death by suicide of 2 cognitive behavior therapists in Ireland, my country of origin. It led me and their CBT colleagues to wonder how we can be more attentive to distress signals in our peers and how we can intervene skillfully and sensitively if necessary." The worksheet on page 111 shown here is one of the first exercises we do with our supervisees because it addresses the issues related to the power differential in the relationship between supervisor and supervisee, and facilitates the discussion about strengths and vulnerabilities. The other 2 worksheets shown here, My Indicators and Compassion, we have found are also helpful for the rapport building while also acknowledging supervision can feel therapeutic. However, it's not therapy. And the Seeking Help on page 111 specifically asks the question, how will you know when you need to seek help? So we have that conversation right up front with our supervisees so that when we come to that point in the supervision conversation, it's not a surprise. This is a list of, this is a list of the items we use as part of the Informed Consent Supervision Agreements. And we introduce this material during a 3.5-hour group orientation and provide 3 reminders as a toolbox moving forward from there. And we use SAMHSA Tip 52 publication, use one of the templates found in that publication for the supervision agreement. Again, you're welcome to have one of the workbooks. You just email me and I'll be glad to email it to you. Although the origin of the parable necessity is the mother of invention, that's debated, I think it's a great way to describe the basic nature of how solutions come to be. The first formally established standards for self-care was initially organized to serve a need in Oklahoma City following the April 19, 1995 bombing of the Alfred Murrah Federal Building. In the purpose for the guidelines, it states, first, do no harm to yourself in the line of duty when helping and treating others. Second, attend to your physical, social, emotional, and spiritual needs as a way of ensuring high-quality services. These principles declare it is unethical not to attend to your self-care because sufficient self-care prevents harm those we're serving. Here's an example of the prompt for a small group activity and facilitates the discussion about self-care. So for us here in the context of a webinar, I'm just going to pause for a few moments to allow you to reflect on these three questions. What is your self-care? How did you learn it? And what gets in the way of practicing it? I want to just mention the concept of ourselves as a therapeutic tool. The motivation for inserting our own lived experience as a strategy for meeting a treatment goal with our clients should not distract from our clients' care and circumstances. This can be a slippery slope to boundary blurring and violation. For myself, seeing the documentary of the anonymous people helped shift my thinking about how lived experience can be a positive messaging tool for recovery and leverage for meaningful policy change and development. The power of connection through genuine empathy, as described by Brené Brown, can be a profound healing resource. The role of our peer support workers utilizes that capacity. Now we'll be moving on to learning objective number 4. Perform the evidence-informed practice of home base as a self-care strategy on the job. So we're going to give our brains a break and do some breathing. This slide introduces home base and is part of the 3.5-hour supervision group orientation that initiates the supervision agreement. Understanding the anatomy of breathing is important for developing sustainable resilience. If you like, pay attention to your breath right now while I talk through this slide. Eric Gentry, one of the trainers from the International Association for Trauma Professionals, emphasizes if we're not regulating our stress response in the moment while on the job, we're not getting the juice from self-care. And the juice being neurobiological change that creates new neuroconnections as a pathway to transform the stress response to a relaxation response. This is what Rick Hansen calls positive self-directed neuroplasticity. He's the author of 2 of my favorite books on this topic, Studying Buddha's Brain and Do Just One Thing. Prior to that research, Herbert Benson published back in 1979 what he calls the relaxation response. In 2000, the Journal of American Medical Association published the first validated evidence that shows diaphragmatic breathing can be equally or more effective at reducing anxiety as compared to when treated by anti-anxiety medication. The image on the lower right corner is an illustration of a cross-section of the human torso showing the heart and lungs. The lungs are shaped like lima beans. You can see the largest capacity of the lungs is located in the back of our body, under the shoulder blades. The image on the left highlights the diaphragm muscle with colors yellow and orange. This muscle enables the lungs to breathe and functions as part of the autonomic nervous system. In other words, we breathe without thinking about it. The smaller illustrations near the top show arrows pointing in the direction of exhale and inhale. The diaphragm goes up and into the rib cage on the exhale and down into the belly outside of the rib cage on the inhale. That's why this type of breathing is also called belly breathing. If you've ever had the pleasure of watching a healthy baby sleep, you've seen this in action. We're born knowing how to do this. Our body knows what it needs. Now I'll share with you the story of how I came to call this practice home base. And it's called an evidence-informed practice because it's based on all the research I've mentioned. However, I haven't taken it through the academic rigors for it to earn the official title of evidence-based, so it's evidence-informed. At the time, I was working in the Department of Corrections as the only full-time behavioral health clinician. My responsibilities included developing and leading 3 groups a day, 5 days a week, plus individual treatment planning and release planning, supervising other staff, among other tasks. At the time, my family was experiencing significant life transitions. I had just returned from a 3-month medical leave in Virginia to help with the transition of our mother onto hospice care. My husband's work had taken him to the West Coast for several years, and our kids were in junior and senior high school. I was meeting with this particular client for release planning. This wasn't the first time we had done this. We were familiar with each other. Their home life was not a healthy environment. I was preoccupied, distracted, sleep deprived, and despite using chair-adapted yoga postures, mindful breathing, investing in additional supervision services for myself, including therapy, I was fatigued. Having spent a lot of time sitting in waiting rooms and driving long distances, I had developed the habit of adjusting my spine and posture to enable full diaphragmatic breathing, and did this frequently while at work. It's a subtle adjustment I had been doing for months without anyone noticing except this time. And this client interrupted me and stated, "Wait a minute, you weren't here before and now you are. I need to learn how to do that. I need to learn how to live here." And he's patting his chest with his hand. He went back and taught this practice to his cellmate, and then we started doing it as part of group on a regular basis. And the group members decided to call it home base instead of that breathing thing that you do while you sit in the chair. They decided to call it home base because it feels like coming home to a safe spot, just like running to home plate in baseball. So if you like, when you're ready, let your body respond to these suggestions. Feet on the floor, long spine, relaxed throat, soft jaw. These are the 5 components we're testing as part of the Informed Consent Supervision Agreement for effectively managing workplace stressors. We're now about 8 months into the project and working with over 20 CRSW candidates and a handful of clinical mental health counselor candidates. The illustration of the triune brain up in the right-hand corner explains 3 major parts of the brain, and it's taught that this slide and what I'm going to walk you through is taught as part of the 3.5-hour orientation to meet one of these 5 components of the compassion fatigue competence in the Informed Consent Supervision Agreement. So in looking at the triune brain, it explains 3 major parts of the brain. The neocortex, our rational brain, the part that's in front, right in our forehead. The limbic brain, which is called the emotional brain, there in yellow, and then red. The reptilian brain, which is where our instinctive drives are, fight, flight, freeze. All of the research generated to find more effective treatment for our combat veterans and better understand the neurophysiology of how trauma impacts brain function has given evidence for identifying more appropriate and effective treatments. This body of evidence has shown that talk therapies have not particularly been effective and at times can cause harm as a treatment approach dealing with trauma. Talk therapy or any cognitive focused process is considered what's called a top-down approach because it activates the rational functioning of the frontal cortex. It's a higher functioning ability. We now know that trauma is experienced and stored in the body through the limbic and the reptilian brain, the lower functions. Therefore, to process these experiences, a bottom-up approach is proven more effective. Bottom-up meaning you're utilizing the lower functions of the brain, so therefore somatic exercises. Our stress response is a bottom-up mechanism of our neurobiology. In order to calm the stress response, strategies must also address that function of our brain. Many people living with substance use disorders also have co-occurring mental health issues, including trauma-related histories. I'm one of those people. And I can attest, my substance use began early in junior high. I was 12, as a way to cope with living in a home impacted by violence. The effects of the alcohol and cannabis were my solution to what felt like an overwhelming trap of helplessness. Facing those core issues in my recovery by talking about them often made things worse for me emotionally. I've been fortunate to consider my body as an ally and to have been encouraged to explore and develop the expressive arts skills of myself. In growing to feel overwhelmed, I grew up feeling empowered by my body. I was an athlete and was able to experience success that way. But for people who have had physical harm, meaning violations, be it physical or sexual assault, the body is not necessarily viewed as an ally. The 7 basic body principles mentioned in those 5 criteria are rooted in the practice, what I've mentioned as somatic psychotherapy. This particular source is one of many that identify these principles. So why include it in clinical supervision? The 3rd criteria of the impaired practice mentioned earlier, 3 being an inability to control personal stress, psychological dysfunction, and/or excessive emotional reactions that interfere with professional functioning. That's one of the 3 criteria of impaired practice. And the ProQual studies show we bring ourselves to work, meaning our lived experience, regardless of it being substance misuse or not. We're human beings drawn together with common interests. Effective clinical supervision and peer collaboration will enable us to navigate the boundaries between our own stuff and our client's stuff. The symptoms of compassion fatigue, vicarious trauma, burnout are products of our mind and body becoming overwhelmed. Mind-body practices engage the brain from bottom up and provide a mechanism for reducing excessive emotional reactions. The research behind this validates resilience is built by engaging the limbic and reptilian brain systems of the brain. James Redford's documentary on resilience uses the subtitle, The Biology of Stress and the Science of Hope. Here are the mentioned 7 basic body principles. The next several slides will review New Hampshire laws and rules related to clinical supervision according to the Licensing Board for Alcohol and Other Drug Counselors and the Board of Mental Health Licensing. So here's our next pause for a question and discussion. According to the triune brain model, which of the following best describe why mind-body practice is important to clinician well-being? Well, all of these 4 options have elements of the correct answer, but the most correct is B. Research has proven resilience is built by engaging the limbic and reptilian parts of the brain. I've found with my clients, reviewing basic understanding of these principles, why do we have to do this breathing thing all the time? The proof is in the pudding, and in that case that I shared with you when working in the Department of Corrections, the proof of the pudding was being represented by one of the participants, so I didn't really have to convince anyone. But if you're working with someone that's in a pre-contemplation stage of thinking, informing them with some of the basic understandings of the anatomy and the function of the anatomical process of breathing. Usually, if people can understand why something's important, it's easier to buy into it. So the important things here is in defining the concept of gatekeeper. And this quote out of the New Hampshire regulations for substance use providers and supervision activity best sums up the concept of gatekeeper and the scope of that practice. And the primary difference between clinical supervision and peer collaboration is the legal responsibility. The supervisor in clinical supervision is assuming legal responsibility for their supervisee, whereas in the peer collaboration process, there is no legal responsibility other than what we bring for ourselves. And here that is spelled out in line C, the legal and ethical responsibility. Here again, from the 9 NADAC principles are several references including self-care, self-monitoring, recognizing impairment. In addition to that, the directive takes steps to assure supervisees and workers have appropriate resources and competencies, and to ensure current knowledge and information is being utilized. It's the hope of the task force that outcomes of this project will provide helpful insights for how to successfully manage workplace stressors by identifying more effective strategies and standards to address the challenges we're facing in today's workforce landscape. These are additional worksheets that we have found helpful in defining the difference between what is a stress factor outside of ourselves and internally. We do have some choices for how to manage the stress, and we found these are helpful with defining the boundaries between the source of the stressors. So here's another opportunity to take a moment now for practicing home base or another practice of your preference, and allow yourself to be mindful of your own work right now. Where do you find meaning and purpose in your work? And what is most difficult? When you notice judgmental or critical thinking, allow your exhale to invite release of the judgment and let it go. Explore your breath as a change agent for reconnecting with the calling of your work, where you find meaning and purpose, or letting go of what is difficult. Just let yourself breathe. The polyvagal theory established by Stephen Porges, he's a professional of psychiatry at the University of North Carolina, gives us even more evidence for the power of the self-directed positive neuroplasticity that's activated by the diaphragmatic breathing. Looking at the drawing on the left, it shows the spinal cord and brain linked to other major organs by the vagus nerve. In the lower right image, the diaphragm is illustrated with yellow and orange colors. Notice how the diaphragm muscle is also attached to the spine where the vagus nerve attaches. Although this is an incredibly oversimplification of how these systems function, diaphragmatic breathing creates change similarly as does acupressure. The movement of the diaphragm muscle up and down the length of the spinal cord stimulates the vagus nerve to tell the rest of the autonomic system, hey, chill out, relax, rest, and digest. This slide is actually right off of the ProQual website. You can go there and download several resources, including already organized PowerPoint slides. And it plants the idea of how are you going to use this information for your own resiliency planning? You could use it for yourself individually, using the ProQual to plot changes over time. It could be used as an organizational planning tool to help either your department or your entire agency find ways to maximize the positive aspects of the work and reduce the negative aspects of helping. And then, of course, in the focus of this project that we're talking about, compassion fatigue sensitive supervision, we're using it as a way to track our progress. We're facilitating the ProQual quarterly, and we're anxious to see the outcomes and hoping that it'll help us draw some links around causal effect for positive change. Here's another example of a professional resilience plan, and it's actually the one that I used for myself. Eric Gentry is the person I completed my training with, and this is his personal design for a professional resiliency plan, and I'm just showing you one of 8 topics of this plan. And what I like about this is it provides a simple justification of what is the mechanism of change and why is it important. And remember, he uses the word juice. He describes self-regulation as the mechanism for getting the juice out of self-care. The juice is the relaxation response. It's the slowing down of our heart rate, slowing down of our breathing, lengthening the exhale. Diaphragmatic breathing and other mind-body practices stimulate a positive neurological response that gives us this juice, stimulated by the production of endorphins and dopamine. The polyvagal theory explains this further. The important thing to remember, if we're not practicing mood regulation in the moment that we're experiencing the stress, we miss out on the juice. That's not to say self-care isn't effective unless we are creating a neurobiological effect. The juice is just simply a supercharged version of self-care. Another way to think about the juice is what Marsha Linehan describes in dialectical behavioral therapy as our wise mind. She added mindfulness to the cognitive behavioral therapy model. And it's mindfulness that is a bottom-up approach combined with the cognitive, which is top-down, that the effectiveness of DBT speaks for itself. I'm a Star Trek fan, so I love this cartoon. Trek here, Spock here, is trying to control or bring order to chaos. And when I think of Spock, I think of our rational brain responding, and Captain Kirk is our emotional brain reacting. When Spock and Kirk work together, they accomplish what would have otherwise been impossible. The wise mind is where the irrational and emotional join together for balance and produces resilience. The juice is the neurobiological change that defines resilience. With resilience, we move from surviving to thriving. Neuropsychologist Rick Hansen describes this bottom-up approach as the way the mind changes the brain Again, we can choose a response. That's our mind's job. Our instinctive automatic drive reacts. That's our brain's job. Another way to think of this is to think of our brain as like a hard drive of a computer. We install software to tell the hard drive what to do in order to get what we want from the software. So, for example, if we want to produce a business letter, we use the software program like Microsoft Word. Home base and other mind-body coping skills is the software to calm the sympathetic response, fight, flight, freeze, and activate the parasympathetic system to calm the mind, body, and brain. These are skills that build resilience. So we bring ourselves to work, right? Our lived experience can be our strength as well as our vulnerability. The landscape of our work environment is in crisis. Risks are higher. I found myself at a crossroads in my work more than once during the past several years, and I know I'm not alone with this experience. I've witnessed and experienced ethical and moral dilemmas in a more intense sort of way, mostly impacted by the high rate of deaths in our communities. In my private practice, I have more EAP referrals and self-referrals presenting with work-related stressors. Respected colleagues have confided in me wanting to leave their practice because of being burned out, including plan for suicide. Today, these colleagues continue to work in their field of practice, however, with changes that have helped them regain balance and sustain their resilience. On this side of my own turning point, I see how maladaptive survival skills developed as a child before I discovered the relief that alcohol and cannabis gave me. I survived on thinking if I worked hard enough to do everything right, if I could prevent my parents from arguing by doing everything ahead of time, or if I wouldn't bother my parents for asking for help or their consult with troubles I was having, that somehow that would keep them from having arguments, or believing asking for help meant betraying my parents and my family. I remember giving myself a pep talk not too recently. You're not craving to get high. You haven't relapsed. Girl, you've got this. You've been through worse. Suck it up, buttercup. In my compromised neurobiological state, irrational thinking felt normal. As mentioned before, in 2017, the National Academy of Medicine presented its call to action for clinician well-being based on 20 years of research, initiated by the 1999 publication of To Err is Human. On the right side, you can see the goals of the task force on the left, and the goals of the National Academy beside of them. During 2018, the planning team of the task force met weekly for 3 months with the Opioid Response Network technical assistance experts, and the task force met quarterly. During that time, discussion with the task force members revealed workplace culture is unique to each professional practice, as well as how each would go about addressing the same issues. Therefore, 4 working groups were formed: healthcare, administrative policy, education, and public safety. Today, you've heard about the progress of the healthcare group. Each group is working autonomously on addressing the needs of their profession and work setting. We've come together quarterly for mutual support and networking. This in itself has been a therapeutic boost for all of us. As I've said, there's no one fits all solution, and I hope that some of these resources we've reviewed today you will find relevant for your setting and circumstances. Earlier this year, excuse me, pause for water, breathe. Earlier this year, NAHADCA, the New Hampshire Association for Alcohol and Drug Abuse Counselors, became the first New Hampshire network organization with the National Academy of Medicine's Call to Action for Clinician Well-being and Resilience. This screenshot from NAHATICA's website, where more information can be found about how to become a network organization, why this matters. The Ethics Committee is developing a toolkit for organizations who want to join the national movement. Visit the NAHATICA website to learn more, or you can send me an email if you're interested in getting involved. Remember, our challenge is to find a way to ride out the wave of this crisis, use its momentum to move toward more effective and sustainable solutions. Start where you are and work with what you have. These final slides list other resources. If you would like a copy of the slides, remember, you can just send me an email and I'll be glad to forward the slides to you. This one comes from the Substance Abuse and Mental Health Services Administration. It's a poster defining the 8 dimensions of wellness. These resources are all found on the National Academy of Medicine's Action Collaborative for Clinician Well-being. The case studies are particularly interesting because they're tracking effectiveness of how organizations are implementing wellness on site. And I believe they have some live webinars available as well, and they've been posted on the NAHATICA training website as well. These are various other resources I have found particularly helpful. I'm sure you know of others as well. The Bounce Back Project, I had the pleasure of meeting Dr. Corey Martin, the co-founder of that program. They have a great resources link on their website. It's a worthwhile trip to see. This is our last slide. I'd love to hear your feedback, questions, continued conversation. Thanks so much for joining me today. Now go get your juice.